Just to let everybody know, if you're going to ASES next week and you want to learn more about Medacta products, NextAR, GRS, or any Medacta shoulder products, you would stop by their product showcase. There'll be a Trio Kitchen inside the Gaylord Hotel. I hope I sound like a good radio announcer now. And they'll be offering hands-on demos for attendees. So I would, everything you hear about tonight will be on display at ASCS next week. I think it's a great opportunity to run the exhibit hall and to see these products we talk about tonight. All right, I'm going to stop this share and I'm going to officially start, even though more people are coming in. Um, I just have to change my view. Speaker view. There we go. Okay. Hello, everybody. I'm Ira Kirschenbaum. I am the editor-in-chief of the Journal of Orthopedic Experience and Innovation. We are joined tonight by two amazing panelists, Shadley Schiffern and Wesley Cox. They will introduce themselves in just a couple of minutes. This is the second Joey open mic that we've had on what I think is amazing technology that is coming to the forefront. When I saw it the last time, I just wanted it yesterday. So we'll start off, Shadley. If you please introduce yourself to everybody.
Yeah, thanks everybody for having me. I'm Shadley Schiffern. I'm practicing down at Ortho Carolina in Charlotte. I did my residency at the University of Utah and then a shoulder and elbow fellowship in Dallas with Buzz Burkhead and Butch Krishnan. Happy to be on with y'all.
Right. Wesley.
Hey, thanks for sharing your Wednesday with us. Wes Cox. I'm in Fayetteville, Arkansas. I actually grew up here and then left for everything and came back after finishing fellowship in San Francisco with Jim Kelly, and had kind of a cool experience with Gene Wolfe and Norris and Kelly's group combined. So it was really good on both sides, and yeah, this is exciting stuff. So thanks for tolerating me this evening.
Well, we'll decide how much toleration was needed at the end.
No live voting, please.
Yeah, no live voting. Right. It'll be ranked choice voting. Don't worry about it. That'll be good. So, Shadley, you have some slides to get us off and running. I want to make sure if anyone has any questions at any time, type them please into the chat room. We will call on you to ask your question, maybe undo your video so we can see who you are and or not. And the faculty will answer them and we'll have a discussion. All right. So, Shad, if you can share your screen, we'll get that going.
There it comes. All right. Slideshow to play. Of course, we just had this running, Ira.
I know.
Uh-huh. Let's see.
There
There
you
we go.
go.
All right. Very good.
Just need a little nudge. Yeah.
All right, so we're the topic of tonight's webinar is navigating glenoid deformity. So we're going to talk a little bit about some of the challenging glenoid cases that Wes and I have seen, and some options for how we manage these difficult glenoids. I'm going to get us started talking a little bit about options from an implant standpoint, some of the pre-op planning that's available now. And then Wes is going to also show us some really cool AR technology that's available to help, both plan and implement these cases. So, all of us deal with glenoid bone defects in the world of shoulder arthroplasty, and they're surprisingly very common. Mark Frankel first, presented on the incidence of glenoid deformity, found as high as 40% of his cases, in even primary cases, had significant glenoid defects. Revision cases, it's as high as 80% or probably even more. And these deformities come in all different shapes and sizes depending on the disease process. We learned from Gilles Walsh initially the classification for glenoid or glenohumeral osteoarthritis with these B2 and B3 biconcave glenoids, which most of us deal with on a daily basis. We then also look at glenoid deformities from the rotator cuff arthropathy pathology, more of the superior wear patterns that Favara classified. And then in the revision setting, obviously there is a whole host of glenoid deformities that we deal with, and these can be either centralized contained defects, defects at the periphery on the glenoid wall, or the ones that are really challenging, which can be the combined defects. So when you see defects on the glenoid side, we have several options for how we manage them. You can try to avoid them. If it's a very small deformity, you can ream down the high side. You have options then to correct deformity, either from a bone grafting standpoint. And now we also have metal augmented implants. And then the next level is even custom glenoid implants. We'll touch a little bit on each one of those. The factors that really influence the decision on what direction you go, there's several of them. Obviously, the defect size or the amount of deformity. The smaller deformities, maybe less than 10 degrees or less than 15 degrees of retroversion, are a little easier to deal with. The ones that are in the medium size, 15 to 45 degrees, you can potentially consider a bone graft or an augment. And then the ones that are really massive are the ones that are more are better off using a custom implant. Depends on the location, whether the defect's contained or uncontained. Obviously, it makes a difference whether it's a primary case or a revision case. In primary cases, you have a humeral head that you can take graft from if you wanted to graft. In the revision cases, you often don't have autograft, and so if you're going to graft, you have to go down the road of allograft in those cases. Also, the patient's bone stock and quality, and what kind of glenoid vault or glenoid wall is intact, because no matter what we put in there, we have to have good bone to anchor it into. So, and we all know about the reaming the high side, sort of the ream and leave philosophy, and this can still be acceptable for smaller deformities. There have been some biomechanical studies that show that you can even leave a base plate unsupported from 30%, even up to 50%, and still be biomechanically stable. When I try to ream a high side down, my goal is to get at least 70% of the base plate supported, but the biomechanical studies show you can even accept less than that and then still have stable fixation. The concern, though, in these cases is you already have bone loss, and if you're reaming down the high side, you're just removing more bone and you're losing more of the bone that you're needing for fixation of the implant. So that's where where I think everybody kind of started to move towards techniques which would either restore bone or allow you to put the implant in without taking away any of that precious bone. Um, Bone grafting of the glenoid has been around for a long time. It's got some definite advantages when you compare that with metal augmented implants. It's cost effective. It gives you the ability to customize the graft to fit the defect. So you have a little bit of you can vary the shape of the bone graft to fit. Um, it also, we say, restores bone stock, but I would say if it incorporates, they don't all incorporate. The bone grafting systems have all come along, and you can now actually, have instrumentation to help you fashion a graft to fit a defect in a little bit easier manner. So there's some instrumentation that makes the bone grafting a little bit easier, and these can be done with autograft or allograft as well. And our French colleagues, Pascal Boileau, their team presented on very good 5 to 10 year follow-up with good incorporation of the bio-RSA. So, there have been some successful studies showing incorporation and healing. The problem is not all of them heal. And so bone grafting is not without concerns. These are usually harder cases. They're more technically difficult. And there is a concern of these grafts not incorporating or not healing or even seeing resorption. So I've had a few of these where it looked good initially. It looked good at a year. It looked good maybe at 2 years. But over time, that bone starts to melt away. And it hasn't always led to led to clinical failure, but it's concerning that you lose some of that graft that you're counting on for support. And there have been some studies that demonstrate this as well. The Rothman group presented on a group of 44 patients with structural bone grafts at an average follow-up of 20 months, and found as high as 25% graft resorption early on, even by 8 months. I think some of those concerns have led us to looking at the option of using metal. And so augmented glenoid base plates have been out since around 2011. These have variable shapes and sizes depending on the implant company. There's some designs that are more of a half wedge, some a step cut, and then more so now it seems majority kind of moving towards even more of a full wedge type design. The advantages of using metal, using an augmented base plate, is it's a lot simpler. It's not as complex as a bone graft case, which makes it a little bit faster in the operating room for most of us. It's very reproducible. The different designs of augments fit a good number of these deformities. You don't need to be concerned about the graft healing. And there's no resorption down the road. So it gives you a little bit more or intraoperative flexibility. And so really these have become my go-to option for the vast majority of the cases I do with glenoid bone loss. And the system that I've been using for these is the glenoid reconstruction system from Medacta. I was just going to mention a few of the design features of this particular implant. It's a 24.5 millimeter diameter circular base plate. It's got a 20 millimeter length post, which is 9 millimeter diameter. And then it has 3 wedge angles. There's a 10 degree, a 15 degree, and a 20 degree angle. The wedge itself does give some embedded lateralization to the glenoid. So the 10 degree wedge has 2.5 millimeters of lateralization. If it goes up to 4 with the 15 degree, and the 20 degree wedge really gives you 5.6 millimeters of lateralization if you're looking for it to lateralize as well as correct deformity. The system has a very nicely designed off-axis reamer that is low profile, fits in well, and it fits. There's a reamer head for the 10, the 15, and the 20 to help you prepare the surface for the wedge. There's an optional central screw which acts as a compression screw that is placed through the post. So I'd say probably in my cases, only maybe 25 to 30% of the cases I'm using a central screw. It really depends on how much glenoid vault you have left beyond the post as to whether you can get much bite with a screw. But it does give you an option for a little bit of additional compression. And then it gives you the option for 4 peripheral screws. And these screws are variable angle. And they also have a dual mechanism where you can compress it, and then it's got a screw within a screw locking mechanism, so you can make it a lock screw construct. The other thing that we've looked at from augmented base plates is the ability to just provide strict lateralization. So it's now really become in vogue for us to lateralize more on the glenoid side for tensioning. And this was another thing we learned a lot from Pascal Boileau with the bio-RSAs of lateralizing the bone. But these implants also have an option of just pure lateralized, a lateralized flat base plate. So these come in +3, +6 lateralized options of the same screw configuration. And because the base plates have now been out for a while, there are some decent sized studies out looking at the results of augmented base plates, both in glenohumeral arthritis, which showed excellent outcomes and no evidence of loosening. Looking at the Favard, E1 through E3 glenoid deformities for cuff tear arthropathy. That was a group that had 68 patients with 40-month follow-up, and they also found excellent outcomes with very little implant failures. And then also looking at a cohort of the glenohumeral osteoarthritic cases, more the Walsh B2, B3, and even some C glenoids. That was another series of 67 patients, followed again 40 months, with only about a 4.5% rate of complications. And then also taking it one step further, there have been a couple of studies that actually looked at bone grafting versus an augmented implant. And both of these studies showed the first study showed less complications in the augmented group compared to bone grafting group. And the second study was a prospective randomized study done by George Athwal that had 41 patients with 2-year follow-up and showed no difference in clinical or radiographic outcomes. Um, so I like the use of this implant, and one of the things that helps to make you more accurate and to use it even better is the use of preoperative planning software. So most of the implant companies do have a preoperative planning software package that you can use, upload the patient's CT scans, and it allows you to plan these cases accurately and then figure out how you want to implement it in the operating room. So this is just an example of one of the cases that we planned. So there's a 69-year-old male with glenohumeral osteoarthritis with a classic kind of B2 biconcave glenoid. And this was his initial, we plug in his initial plan. He had 91% posterior subluxation of the humeral head. And this just kind of shows his initial deformity. That humeral head wants to sit, back in the B2 uh, biconcavity back there. Move on. Next. A pretty standard deformity that we deal with. And using the system, you can plan this and decide exactly where you want to put your central pin to be able to have the best fixation, the longest amount of vault that you have available to you. So you can actually kind of play around with where you have the best bone to actually fit your implant. This again, the measurements on this glenoid showed 5 degrees of inferior inclination and 37 degrees of glenoid retroversion for this particular case. And this is what it would look like if we used just a standard flat base plate with this kind of deformity. You can see how far that base plate's sitting up with the amount of retroversion on that glenoid. If you try to ream that high side down to make that base plate fit, you're going to be removing an awful lot of bone from that front of the glenoid, and that's something I would definitely not want to do in these cases. Sorry. So the option then is to either use a bone graft that you can plan with the software or a wedge. This was planned for a 20-degree wedge augment, and looking at the wedge on the plan, it fits in there really nicely, and you really don't have to remove very little bone. You remove a little bit of that anterior rim to make that fit, but it's a very bone preserving. You can also plan on this particular system. You can plan on the humerus. I don't think it's as crucial in these cases for humeral planning for most of us, but it does give you an option if you have a particular humerus that has some deformity, malunion, something like that. It gives you that option. And then this is what it looks like when you put both implants together. It gives you a really nice illustration. It actually, you can take it through live motion to see. It allows you to see how much mobility you have in each plane before you would get impingement in any plane. So it's kind of nice to be able to see that ahead of time, know where your implants are going to fit. So this is post-op X-rays on this particular patient. This was a 20-degree wedge. We were able to correct his retroversion back to pretty close to neutral. I know it's something we'll talk about a little bit later. Is do you have to correct it all the way back? I would say, especially in reverse cases, you don't have to, but I try to correct it back to as close to neutral as I can. And then we just also wanted to talk a little bit about custom glenoid implants. These really are the becoming the go-to cases for these cases of massive glenoid bone deformity and bone loss. These also definitely require CT-based planning. They have not been around as long as the augmented base plates, so there's less long-term follow-up on them, but a couple short series, small numbers of patients with 2.5, 3 year follow-up, which have shown good results. I'm going to skip over this one and go to this case. This was a case we wanted to just illustrate. It's actually a case of John Bell up at Dartmouth. So this patient has this significant cuff tear arthropathy, deformity with medial erosion, massive amount of glenoid bone loss. And this was his initial CT scan. You can see I mean, the erosion is way back past the base of the coracoid process. Really significant, both medial and superior glenoid erosion. This was John's initial look at the pre-op plan, and look at how much bone there is missing back there. There's just really no way you're gonna be able to put something in there with a wedge, or a bone graft would have to be a massive bone graft to really fill this type of deformity. So the options, like we went through, off the shelf, a bone graft. The bone graft challenge is just like I illustrated before, and so you also have to take into case a lot of times these patient considerations. These patients are usually very quite disabled, not only with pain but limited use. So they're pretty desperate for an answer, but they need to understand, what they're getting themselves into in these cases, because these cases certainly are at high risk. It's a high risk situation with a lot of issues that can go wrong. So I think in these cases, whenever I've planned these and done them, these are long conversations with the patients pre-op. That being said, this was another study that looked at 62 patients with the Biomet VRS custom glenoid follow-up. These had 89% 2 year follow-ups. And they had excellent functional improvement and excellent improvements in VRS pain scores. But just to illustrate, it was about a 29% complication rate. And these come in all the normal complications we see, instability being very common, infection, fractures. So these are challenging cases. This is a rendering of the model when the engineer started to look at planning this with John, kind of just again demonstrating the amount of deformity here. This one to play. Sorry. And then they initially started to look at kind of a draft of what kind of option that they could give him. The nice thing with a lot of these custom implants is not only do they help you design the implant itself, but you also design custom instrumentation. So being able to navigate and put the post where it needs to go. It helps you to even shoot the screws, because these cases a lot of times it's difficult to get screws into good bone too. So having guides that can help you with screw placement is important as well. I think John just demonstrating again the bone model that they can send you out to, so you can actually beforehand and you can play around with it, know exactly where the implant needs to sit. These could be sterilely processed and brought into the OR too. So I usually bring them onto the field, and it helps when you're to actually compare what you're looking at with what you planned. This was an example, kind of looking at what they were the planning with this particular case, what they came up with for him. Some intraoperative photos, and this is looking at it. So, this was a case that a lot of folks would not want to tackle, but having this as an option, I think, really opens the door for us to help a lot of these patients. So, thanks a lot. I'm gonna turn it over to Wes, and we can then have a good discussion after.
All right.
All right, thanks, Shad. See if I can. Tell me when I'm clear to share. Shad, you may have to unshare.
Yeah, yeah.
I got it. I got it.
Oh, you got it. Okay. Thanks, Aaron.
Pinch hitter, backup
Right.
quarterback. How long is the process, Shed, on the custom?
It's gotten a lot shorter. I think in a lot of cases you can get it down to somewhere in the 4 to 6 week range, at
Oh,
least with the systems that I'm familiar with.
very
All right,
good.
should be good now.
Would you say, Wes? Is that about
Yeah,
right?
yeah, much quicker than you know seems reasonable. I mean, it's kind of crazy. Um, all right, can y'all see mine?
Yep.
Yep.
All right. Well, thanks. Shad had the a lot more of the technical stuff, and I had the luxury of discussing a little bit more sort of high level about sort of where we are now and some other options, and we'll talk about the augmented reality option that we've been doing as well. So next AR is Medatka's augmented reality platform. We'll talk about it at a high level, talk a little bit about why I like it, and then maybe look at a couple of quick cases. These are the glasses, at least the ones that are currently being worn. I will tell you that a lot of people don't use the glasses. You don't have to. The way I describe it is the glasses work kind of like a heads up display on your car. You can see the miles per hour. You can see whatever music you're listening to, but it doesn't obstruct your view of anything. Some people don't like having that there, so they just go off the screen. But I wear them. So essentially the ingredients to Nexstar is a pre-planned strategy, which Shad did a good job of showing us. And then for me, the key is that I don't want something that's super intrusive. I don't have to change what I'm doing or where I'm standing or my flow or all the things. So one monitor in the room and the glasses, obviously, if you want them. It's a lens and camera system. So every instrument has the camera has the lens on it so that it's communicating with a mounted lens that's mounted to the coracoid, and the feedback is on every step. So it's really nice. What I love about it, it gives you real-time feedback, which I'll show you, but also the ability to change. You can do anything you want. You're not bought in on only the plan, but it's still giving you guidance and telling you what you're doing, even if you're intentionally deviating from the plan for some reason. And then the peripheral screw placement is essentially like putting the screws in the CT scan, which is really awesome. So this is my normal setup for a right total shoulder. It's my PA at 12 o'clock there, and me and my scrubs just off the screen. And we're doing Nexstar here. I've got the glasses on, but you can tell it's just a normal setup. Um, but so the rationale here on why I bought in early and have really loved the journey is that I heard one of my mentors one time say that our experience creates bias, and we have to be real cognizant of that. And I use golf as an analogy a lot in this talk, so apologies. But Tiger Woods was dominating the world in golf when he changed swing coaches and said he thought he could be better, and everyone thought he was crazy, and he was better. I mean, I think just because you're having success doesn't mean you can't have it more often. I think what we need to think about is it's easy to look at wins, but sometimes to get better, I think we have to look at misses. So the question is, why do we miss when we miss? We've all gotten a post-op X-ray, at least I have. I won't put everybody in the bucket. And I've thought, man, that is not the tilt I thought, or that's something different. It's just because we're human. You have the perfect target, and we just fail to execute, even with good instruments and guides and systems. Sometimes you just don't get it right. I think probably more often than not, we just get fooled that it never really had a chance. We had the wrong target to begin with. You could perfectly execute with the wrong target and still miss. And so the analogy I use with my patients, or the sort of the metaphor I use with my patients to describe when I'm telling them about augmented reality and what we're going to do and so forth, is if I want these 9 pictures sort of neatly and hung in an OCD manner at my house, and you're starting with this blank wall, what Nexstar does for me is allows me to see both of these at the same time. And so I tell my patients it's like hanging pictures or towel racks or anything, TV projectors. You're hanging it and you're looking at the sheetrock. You're working normally, but you have these sort of magic glasses on that allow me to see the studs at the same time. Um, and so the question becomes, well, I mean, is it cute, for lack of a better word, or does it actually help? And I think it allows me to see things that were impossible before. to see the map and the target. It's live, it's accurate. But most importantly, you're finding out right then if your read was good before you putt, rather than waiting on a post-op X-ray. The ability to still do your thing, be a surgeon, change your plan, change your mind, and still get feedback is nice, and I'll show you that. And the bottom line is it tells you the truth. Um, Optical illusions, unseen undulations. Unlike putting, you don't get to lean down and feel it and walk around and see it from the other side. You've got one perspective to determine how accurate we are. So this is registration step where we're registering the glenoid, making sure that we're matching up with the CT scan. It's pretty quick, takes me about a minute to a minute and a half. It's guided, so you can see the color changes, and it's guiding me through these different points. One question we get a lot is, do we expose the coracoid? I do not expose the coracoid at all. The pointer for the system is very sharp, and you're pretty close to the base, and you can get your points from anywhere on the coracoid, including the coracoid tip and other areas, so it's pretty easy. When this is kind of a video, we'll blame it on my Datka rep, Eric, if he's on here. He's kind enough to do the video for me. I shouldn't say that. So what we're looking at here is I'm reaming, and I haven't started running the reamer yet, but what we see in gray on the left is the patient's native anatomy. Sorry, bad timing. It's me working. I'm using the glasses a little bit, and then looking back, and I'll pause when we get back to the screen. So on the left side, the patient's normal anatomy, the green is what we planned, and I'm looking at reaming depth, superior inclination, which is what the Swiss call it, rather than inferior tilt, so it comes in a negative number, and then retroversion. And so green is what we planned, blue is where I am, and you can actually see I'm using a threaded base plate in this case, and you can see the green plan and the blue overlay as we work. The numbers will get a little jumpy as I'm reaming, but it's also showing me what I reamed there with the blue highlight. I'm putting the base plate in here, and again, I'm getting depth, rotation, inclination, real time, and even the base plate inserter has the camera on it. And you can see not a bunch of extra work required to keep going. So I'll just show a couple of cases, that we've used it in, and this one was kind of daunting. The worst part about this guy was that I did his other shoulder about 11 years prior to this, and it was the biggest chip shot ever. He had no deformity. He just had a big, massive cuff tear. And he came in and actually saw my partner first and said, because, I don't know, he could see him quicker or something. And my partner said, look at this CT scan. This guy wants me to do exactly what you did on his chip shot. So he's sending back over to me, and we use Nexstar. So this is just a really up close view of his, like, while I'm registering, looking at this very large anterior rim. So it's not that, I mean, you can see the retroversion, but like this view, when you start taking this much bone, if that's the plan, you can get into trouble, and also you may not even be right. And so this is the intraoperative look at this case. The screen on the left, I didn't really go over pin placement, but it's a targeting, sort of just like a missile on a fighter jet or something, where the green is our planned and the blue is where I am, and we just kind of he took the picture sort of midway. But this was planned for a very large graft, and ultimately what we did, I'll skip that. So this was using the graft system that Adatka has to offer, so you can plan for the graft and then set the graft harvesting up so that there's not a lot of work involved. I still use threaded base plates on grafts like this most of the time. That's contrary to what a lot of people do, I know, but for me, it works because I still like to feel my purchase as I'm going in. So this is him. This was a can't remember how long follow-up this was, but enough to where he was already doing great. We made sure of that before we took pictures. But you can see the graft on both of those pictures, really up close there on the one on the right. Another case, we've all seen these, and I planned this one for this was actually, we didn't have the ability to do the GRS wedge planning effectively until recently. And so I planned this for a graft and intentionally set up for a 20-degree graft so that I could use a 20-degree wedge and still use the next AR system to place my pin and do that. So we kind of used it as if we were going to graft. This is that case. And the green dots are some of the registration points. I just intentionally rotated it so that for effect here. But again, this big rim and the retroversion can really fool you. And then this is what Shad has already shown us. This case was just recently, maybe 3 or 4 months ago. This big osteophyte at the inferior glenoid. I mean, you see it. It's like, yeah, okay, but it does not do justice until we're looking at it. I know I would have been fooled by it. Let's see. I think this is a video. So I'm sorry. Go on the picture on the right, and you almost look more through the transparent. It wasn't just an anterior rim. Inferiorly, it was significantly more substantial and thick. So it didn't feel like osteophyte, even didn't behave like osteophyte. It wasn't. I mean, it was worn, but it was very tricky. And without Nexstar, I don't know where I would have put it, but it wouldn't have been there probably. That's the safest way to say it. And that's the post-op, same 20-degree wedge, 20-degree post, and peripheral screws. Last case I'll show you was just a couple of months ago also, but I actually met this patient 16 years ago when he was a 17-year-old kid and was hit by a 18-wheeler on a motorcycle. And I had just started practice, rotted both his femurs, amputated one of his BKs, actually plated the body of his scapula, later went back and took some of it out. He just didn't like the hardware, especially on his acromion. But his subsequent deformity of his scapula now at like 36 years old was significant. So I used Nexstar on him for a variety of reasons, mostly because just trying to hit a home run for this guy. His cuff was also no good. So this is him, and you can see the fracture kind of deformity in the body of the scapula there. I was nervous about getting into some sort of a aquifer of sorts and not having stable fixation. So it was a high demand case without a ton of deformity, but certainty on the backside too of the scapula was critically important for me. So this is what our plans look like. Again, just real medialized, almost just looked like, kind of classic RA, but it wasn't. Anyway, here he is, and was great. You might notice, so I cheat the system. One of the friend named this gentleman's Varus. This is a 45-degree cup, and in some of these situations, I like just a little bit more. So we err for just a little bit of Varus sometimes to get to the 135 angle. All these implants, let me unshare here while I'm talking. All these implants we're talking about, I do think getting your hands on them is super helpful. I'm not going to be at ASCS because it's my son's birthday and he's playing in a golf tournament, so I'll be there. But it's good to see it and to get it in your hands. The next AR is easy to use, so and getting easier. The software updates are nonstop and they're seamless. You never even know they happen. It just seems to go smoother every time. So, any questions that we can talk about or anything you want to talk about, any of us can take it.
I think the other point too is that the next generation of the My Shoulder planning software also comes out this month. And as Wes alluded to, it'll have all the options of the GRS base plates. You pick any one you want off the planning because right now we have had to do the workaround like Wes showed you. But it also is going to be a little bit easier from the standpoint of uploading the scan, and that you can upload the scan and it's immediately available for you to plan right there. There's not as much back and forth between, engineers and you. You can do a lot of it, and so it's pretty quick. I like the nice thing with Nexstar is you could literally sit at your house the night before, or the day of, and plan the case, and then act on it that day. Like, you do the case on Nexstar, whereas if you're doing PSI guides, there is turnaround to that. So you got to plan a couple weeks ahead to get a PSI guide. Whereas if you plan it and then navigate it, like Wes showed, it's pretty instantaneous.
So,
I have a question. Just like any innovation that we think about, we think that whether it's a digital camera, something as simple as that, you know, if I try to sell you a regular camera now that we live in the digital world, you know, it would be a tough sell. It would be a tough sell. Yeah, you take this picture, you send it to a photo mat, and you get it back in an hour, even an hour. You're not selling it. Is there any case scenario where you wouldn't use NextAR? I mean, why would you not use it? I mean, that's
that's a great question. Practically, I'll tell you my flow is that um, if if the patient already has an MRI or a CT scan and they do not have any sort of moderate or more bony deformity, then I'm not having them pay for an additional scan so that I can do Nexstar. Other than that, I'm doing it and trying to do it in everyone that, and by that I mean that the patient's willing to go get a CT and do all these things, which is usually the case that they'll do it. They're happy to do it, but I'm not making them repeat a scan so that because the protocols are a little different for the Nexstar, and it's they're not difficult and it's seamless, and the company takes care of it with the MRI techs, but I'm not making them pay for an additional scan. Otherwise, I'm getting a scan if they haven't had one and do the Nexstar uh, protocol and do Nexstar. I think even on the simplest ones, I've been surprised several times that I would say, that pin looks a little anterior. I think is the most common thing that I'm surprised by on Nexstar and minimal deformity is that the pin looks a little anterior, and then you ream and it's not anterior at all. And again, I think it's just being fooled by maybe a little bit of retroversion, 10, 12 degrees, something like that.
It's a great question, Ira, and I don't use it all the time myself. I'm probably gravitating more towards that maybe, but there are some cases that I look at on plain X-rays and feel like, wow, I think that's a pretty straightforward case. I probably could do that without guidance, but to Wes's point, there may be things that we're not picking up that we could be better. We think we're good at it, but we could probably be a little bit better on it. I do wonder, one of the things I wonder, and I don't know the answer to this necessarily, is, but when we're teaching residents, if they're only learning on nav, is that missing opportunity to learn how to do the case without nav? And we've kind of seen that with the evolution of arthroscopy. Now none of the residents coming out know how to do open cup surgery or anything because they don't see it anymore. But I don't know. I don't know about.
Yeah, I mean, this has been a challenge in all areas of orthopedics for us with, the robotic store. We have joint replacement surgeons who use robots all the time, and some who just net use them for difficult cases. And but there's a case, I guess, for the idea that as was said, you think it's a chip shot, but until you miss it,
Right.
and
Right.
you,
Yeah.
Exactly.
and then
That's
you don't
exactly
make the
right.
cut.
Right.
Here the cut is, oh well, I didn't make the cut in this PGA tournament. No, no, this is a patient's shoulder.
Yeah. Different cut.
So
That's exactly
Amen.
right.
there's a great case for this. Could you imagine, Wes, imagine that looking back on your your semi-extended career, um, looking back and saying, "Oh my God, I did all those cases without this."
I I think it's in play. I think it's in play. I was asked, uh, Dr. Cuomo asked me at a meeting. I was talking about Nexstar. She said, "What's the hardest Nexstar case that you've done?" And I said, "I'm going to tease the question because I think the hardest reverse that I've remember doing in a while, like psychologically, not technically difficult, maybe, was the day I did my first Nexstar live. I'd done it in cadavers and everything, but the first one I did, the very next case, I did not have it. And I had just watched these negligible movements take me from 5 to 8 to 10 degrees of inclination. And it doesn't even feel like you're really moving. And I think what's been eye opening for me is that we have these debates about, do you correct to 5? Do you correct to 10? What do you do? And the reality is, if you don't have some sort of digital feedback, I don't know that we know what we're doing. I think I probably do the same thing every time, but maybe I call it 5 and it's really 10 and so forth. But really amazed at how small motions, especially in inclination,
Yeah.
with really the guide wire. I mean, after that, most of our systems that are available, you get the guide wire right, you can go over the top of it and be pretty close to it. But it's eye opening. I will say that to see how micro motions have macro changes on the screen.
Ted, your
Wes,
thoughts? Yeah.
Wes, you mentioned, how fast it was for the registration and things. Overall, would you have a much more vast experience with it than I do? How much time do you think it adds to your case workflow now that you're kind of humming with it?
Zero. None. But I think there's a couple things built in. I think on average, it's probably right around zero. I think there are probably the super chip shot, non-deformed, massive cuff tear in a tiny person that there is no like, hey, let me see the guide one more time, or hold on, give me
Hmm.
the reamer back. Like
Hmm.
those moves. I think Nexstar takes all of those moves away. It takes
Yeah.
putting a pin, maybe looking at it. Let me see the guide again. All those moves go away with Nexstar. I think the learning curve, the first time you do it, is probably slower than even when you did it in a cadaver because it's
Hmm.
real.
Yeah.
So you fly through it in a cadaver, and then you get back to that probably after, I don't know, single digit cases, maybe 4 or 5 cases. And then I think it adds a little bit of time
Hmm.
until you get maybe 10, 12 cases. And I'm just sort of ballparking, but we had a
Hmm.
meeting when the international Nexstar group got together in Lugano. It was interesting that many of the Europeans thought that it added about 5 to 10 minutes. And none of the Europeans that were there that said that were using the glasses. I do think that there's a lot of this sort of up and down
Hmm.
motion
Hmm.
that is different. I register almost exclusively just through the glasses.
Hmm.
And so I'm never having to turn. It's efficient for me.
Yeah.
Yeah.
Great. Walter, you had a question.
Yeah, so great job, gentlemen, summarizing a lot of this technology. The cases are great to watch. So I guess, Wes, my question was for you about, obviously where the rubber meets the road with all this technology and additional cost is how it translates into clinical outcomes and whether you can demonstrate a difference. So my question is now that you're incorporating Nexstar routinely, it sounds like, except for, kind of the very basic reverses, have you gone back and looked at your clinical outcomes, or have you anecdotally seen any changes in your patient outcomes to feel like that is translating into a significant difference? Or at this point, is it too early to tell, or is the change too subtle? How would you characterize that?
So of the Nexstar users, Bell has more data than anybody. The guy with the crazy case that Shad shared, I would say we are gathering data, but it's that's the other beauty of the Nexstar system is it knows where you put every implant. Like they're registered and saved, and so the ability to go back, longer term follow up, I think, is where this is really I'm most excited about. I'm most particularly interested in if any of my random algorithms I've figured out for additional internal rotation and so forth are accurate. Because once we can retrospectively look back at range of motion relative to actual implant placement rather than looking at a CT or an X-ray and trying to take measurements. All that to say, I haven't published it at all, which is embarrassing, but nonetheless the truth. I will say anecdotally, those cases that I showed were not emotionally challenging for me at all, which I don't know what the value on that is, but to me it's a lot. So the peace of mind in especially big deformities and grafts and wedges, it's like literally just on to the next case. It's like they've become regular cases sort of emotionally and from a preparation standpoint. I will say that I haven't seen any reduction in any of the big things. Like I haven't seen any changes in dislocations. I don't think I'm dislocating less. I don't think we're seeing acromial fractures less. I've had a dislocation in an X-star. I've had an acromial fracture in an X-star, and it seems like we're about on par from a major complication. I think the interesting thing will be to see, as with the break point doing 12, let's say, total shoulders a year. I think we can get the bell curve of outliers a lot tighter with it, which I know was the argument of going all the way back to Psy knees 15 years ago or whatever Depew had. I can't remember what it was called, something like that. But in the hands of really experienced knee surgeons, a lot of the guidance didn't show much difference. The good news here is there's not a huge clinical cost impact. So the disposables, I'll just say that me using NextStar is still less expensive for my hospital than either of the two systems I was using before.
Well, and I think you've touched on, two things that I think are worth mentioning. Number one is, cost is unfortunately kind of part of the equation. There's been this explosion of technology, and that goes back to pre-op planning, the patient specific, now to guidance, and then obviously the customs. And, for me, I'm in private practice and I try to do every case I can in our own surgery center. And especially now that we're able to do Medicare arthroplasty in the surgery center, those margins are not all that impressive. And once you start throwing, all the bells and whistles in, then all of a sudden you're break even or you're even kind of a money loser. And to Ira's question earlier about why would you not use these things, unfortunately, the reality is that, you're trying to balance, what you feel like is best for your patient while also balancing what's reasonable as a businessman. And we find that to be kind of the biggest limiting factor for us in terms of incorporating some of these things, at least in our older patients. And then I think the other thing that's worth mentioning is, a system like this, as well as preoperative planning and everything, can make sure that your implant's well positioned. It can make sure you don't have early bony impingement, et cetera. But there's still a soft tissue component to these cases. There's still soft tissue balancing and there's still tensioning. And these are the things that create, instability or create acromial fractures in part. Obviously, that's multifactorial. But, I think as good as we can be from a technology standpoint, there still is a role for some art and experience.
Yeah,
And,
absolutely.
I think that, this can't do everything for you and keep you out of trouble. You have to incorporate it. It's a tool, just like everything else, and just learning how to maximize the value of that tool is kind of where the key is.
Walter, I think that's perfectly said. I mean, I think too, this is probably, if we could go forward in time, we're probably sitting here talking about DVDs and how much you don't have to rewind them anymore, and all these things, and 3 or 4 years from now, we'll probably be able to have sensor feedback on tension and these things, but there's still a feel component that is, especially in anatomics. I mean, reverses, it matters too, but in my hands, an anatomic is much more of a soft tissue procedure. It's just like you get the bones out of the way and then work on the soft tissues, and we do have this for it. NextStar is available for anatomics as well. We've only shown it in reverses, but it is there too. I will say from a cost standpoint, initially it was cost prohibitive as a capital equipment investment in the software. and that's no longer required. So I don't know the details of that. I just know that there's opportunities ambulatory wise that aren't that are a lot different than they were just like maybe a year ago or less.
Sure. Yeah, that's great.
Yeah.
Yeah, so this is amazing. This might have been the fastest hour of the fastest hour in orthopedics, which is Joey open mics. Um, it's amazing. We could have gotten 3 reverse shoulders done during this time period.
That's right.
I
Right.
would like to ask our panelists to sum up, but before I just now that we have everybody on board, I do again want to remind everybody here that if you're attending ACES next week, you want to learn more about NextAR, GRS, or any Medacta shoulder products, there'll be a showcase at the Trio Kitchen inside the Gaylord Hotel, offering hands-on demos. As Shadley said, and I think all the panelists and our guest star panelist Walter, I'd like to say, getting your hands on this stuff at these exhibits and feeling it and getting a sense of it will put you way ahead of the curve. So I'd like each of you to sum up. Shad, you want to sum up a little bit, and then I'll ask Wesley to bring us home.
Yeah, no, I think it's an exciting time to be a shoulder arthroplasty surgeon. We have a lot more tools now in our toolbox, and both from the implant standpoint, we have some options now, and to Walter's point, the cost is a huge concern, obviously, but there's more and more implants coming down the pipe that are more patient specific, implants that we'll have to just see how that fits in. But it's exciting time. 100% agree. The operation, more than half the operation is balancing the soft tissues, and the part we're doing with implant positioning is only one part of it, but pretty cool technology that we now have available.
Wes, you want to bring us home as the last comments of the night?
Yeah. I appreciate everybody's time. I know it's middle of the week is you're not yet coasting and you're already a little bit tired. So this is courteous of everybody to be here. I learn a lot just listening to everybody talk. And Walter, I appreciate your injection. I mean, I think what we have more options for the same problem than I think we've ever had. Like you could have the same deformity and have a couple of different ways to address it. It feels like we haven't really had that before in the severe cases, and so the ability to do that, I think, is changing everything. I can't wait to see where this is a year from now. I bet we'll laugh at these slides and say, "Oh my gosh, that's how we did it a year ago." But that's the way it's supposed to be. I'll leave it with Gene Wolfe in my fellowship said that when I was finishing up, he said, "If you're doing anything the exact same way 5 years from now as I taught you, then I haven't really taught you much of anything." And I think there's a lot of wisdom in that, but it doesn't mean that you can't be a skeptic. We don't have to be first on board. I worked on the Next Star project for I think nearly 2 years before I ever put one in anybody. So I wasn't as quick to jump as it may have seemed, but once I jumped, I've been in. So, and I'm always available. I'm easy to find. My number's probably written on all the truck stop bathrooms or something. So find me if you need me. If you have questions, if I've said something that sounds outrageous, I'm always happy to help. Ira, you're a gracious host. Thank you.
I
Thanks, Ira.
thank you so much. This has been a great session, a great product, and a great innovation. I want to thank everyone for coming tonight. And we'll say good night and hope the Yankees win tonight.
You can say that.
Good
I
luck,
can say
Ira.
that. I can say that.
All
Have a
right.
great night, everybody.
Good
Good
night,
night.
guys.
Take
Great
care,
job.
guys.